All right, I can record now. That's perfect. Um, 1 second. All right, so we are ready to start. Good morning, everyone, and good afternoon for those who are on the other side of the hemisphere. My name is Ivan, and I'm one of the senior fellows in Muhimbili in Tanzania. We are proud to have Dr. Todd Schlachter from Yale. Dr. Todd is an assistant professor of medicine and imaging sciences at Yale School of Medicine, and he'll be speaking to us on a short history of interventional radiology, which is something that is really important, especially for people training in interventional radiology, and very good inspiration of what interventional radiology can do and the real path of interventional radiology. Dr. Todd, our audience is mainly consisting of IR fellows from Tanzania, uh, residents from radiology from Rwanda, and other many IR enthusiasts and students from other parts of the world, mainly India, and we have had others joining from the US as well. So we keep on having people subscribing in and coming for these lectures. So we might have a bigger number as we go on. You're welcome.
Ah, Thank you very much for the kind introduction. So yeah, I'm going to give a brief history of interventional radiology. I hope it's relevant for everyone here. In revamping the lecture, I reread about some of the giants in interventional radiology. And one thing that I found in common with many of them is their passion their general passion. So their fire, their willingness to connect, which I'm saying is the word wire, and their perseverance, which is grit. So I'm a member of likely the third generation of interventional radiologists to begin after Charles Dotter passed away in 1985. I came from a radiology practice which Bob White worked under, and he was one of the founding members of the SIR before it was the SIR. Bob White trained Sally Mitchell, who subsequently trained me in my fellowship. And then Bob White came to Yale and apprenticed Jeff Pollack, who trained under Constantine Cope. I never met I never met Charles Dotter, but I did meet Bob White. Unfortunately, I never got to know him, but I do realize that his inspiration has enriched my professional life this whole time. So all these names are probably foreign to everyone. And so that's why we're going to go into some of the history to start realizing that there is a connection between us all in interventional radiology. I'm going to start here with, this was my, after fellowship, I was a lone fellow that stayed on as an attending and had the pleasure of carrying something called a CVDL pager. There's a cardiovascular lab pager, and I was carrying it with one of my newly minted fellows, Raphael. We had just finished a day's work, rounding, triaging cases, and discussing acronyms in the hospital versus social conversation. Particularly, Raphael liked FU for follow-up. That's not how he originally interpreted it. And we were having a long discussion about that as we got a consult on a 36-year-old male who had pancreatic cancer and was starting an experimental drug and started massively hemorrhaging. So we got a CT which showed massive hemorrhage off the SMA. And so we immediately brought him into the suite, into the IR suite. And it was, I think it was around 1 a.m. And we did this, we got brachial access. And we immediately do this angiogram. And if you see here, this little nubbin is a pseudoaneurysm directly off of the SMA. And so using the techniques that were developed before us. We were able to cross the lesion. And then right here, you can see a stent, a covered stent being deployed. And then the final looks like that. So although, this patient did eventually come to his pancreatic cancer, we did save him that night, and he actually lived for another year and a half afterwards. And so that was pretty amazing. And so let me go on to show you another, this is the final, another case that I was standing on the Giants for. This was one of my first weekend on call at Yale. And for this case, I had to summarize it in about a 2-minute little video here. I was literally standing on the Giants. I'm going to skip to the next slide because I think it's a bigger screen. Literally standing on the Giants of people from the 1950s to the 1990s to accomplish this. This was in about a 50-year-old male with cirrhosis that was bleeding from massive esophageal varices. And what we were able to do with portal vein occlusion, what we were able to do is decompress this portal vein and embolize the varices. Some of the movie's not working. But let's begin with the actual history. So the prologue. To put it in context, within the art and science of medicine, there are 3 major categories of technological development. First major breakthrough was obviously the Rankine ray. Sir Wilhelm Rankine, a German physics professor, discovered it on November 8th in 1895 when he was working in a vacuum, it was vacuum thesis, and he was able to move objects in front of the X-ray tube, and he essentially was able to take an X-ray. Eventually, when he immobilized his wife's hand in the path of the rays of the photographic plate, he observed that his wife's hand had shadows, bones, and their wedding ring. And that was the first Rankine ray ever taken. The next big development, major technical development, was Werner Forsum. In 1929, the physician Werner Forsman saw a picture in a book showing how a tube was inserted into the heart of a horse through a vein. A balloon at the end of the tube showed pressure changes, and he was convinced that a similar experiment could be carried out in people. Despite the fact that his boss forbade him, Werner Forsman conducted the experiment on himself. He accessed the crook of his arm and pushed a thin, essentially like a Fogarty catheter, Foley catheter, into his vein, and then walked over to X-ray and took an X-ray. And you can see, and eventually he won with 2 other gentlemen a Nobel Prize for doing this. He did unfortunately lose his job for, going against his boss's wishes, which is, that's part of the grit that occurs in interventional radiology. The third major contribution was Selingers. Selingers' contribution belongs to the category of transcending significance, as it continues to play a role in modern radiologic practice in ways that he never even imagined. So Selinger recounts in an interview with him, he recounted that once, after an unsuccessful attempt of using another technique, he stood in his lab quite sad with 3 items in his hand: the needle, the guide wire, and the catheter. And suddenly, he was aware of how they should properly be used. He described it as a severe attack of common sense. Within a split second, he realized how they should be used, and he described it as needle in, guide wire in through needle, needle out, catheter over wire, and finally remove the guide wire. This happened in April of 1952. Years later, one of the great radiologists described it as it is almost impossible to imagine life today with things you are used to growing up with. And that is the benefit of Selingers technique. We sometimes forget to call it Selingers technique in our dictations, but that is essentially how we access every vessel, every abscess, and almost every procedure any catheter wire procedure that we do. So that was the prologue. And then the beginning started with the imagination, innovation, and patient caring of one person who was standing on the giants of the people before him, but he believed in a poem by Ralph Waldo Emerson that said, "Do not go where there is no path. There is a path. Go where there is no path and leave a trail." And so, does Fabian wanted to make this somewhat interactive. I'm not sure how that's going to be, so I'm going to ask some rhetorical questions here. So, who is considered the father of interventional radiology?
And maybe people should use the chat.
Okay. And the answer is Charles Theodore Dotter, and that's a name that you heard from my brief synopsis in the beginning of my life. Charles Dotter was born in Boston, June 14th, 1920. He went to high school in Long Island. He eventually graduated from Duke, got his MD from Cornell, and then he published voraciously while at Cornell, and at 32 years of age, he became the youngest academic chair in the University of Oregon. So when was IR conceived? I don't know why this is skipping. It was conceived June 19th, 1963. So early in 1963, Dotter's first arterial recanalization was inadvertent. He accidentally recanalized an occluded right iliac artery by passing a percutaneously introduced catheter retrograde through the occlusion to perform an abdominal arteriogram. He noted this, and in the mid 1963, at the Czechoslovakian Radiology Conference, after an hour presentation, he noted that the angiographic catheter can be more than a tool for passive means for diagnostic observation. With imagination, it can become an important surgical instrument. And that was a critical shift in thinking. It was unheard of to use one of these angiographic catheters for actually an intervention. It was prior to this moment, it was only used for diagnostic purposes. So that was in Czechoslovakia in the mid 1963. Later that year, he met this person named Bill Cook at RSNA in Chicago. Bill Cook owned Cook Incorporated. Bill Cook was the only employee of said company, Cook Incorporated. But they met and they bonded well over steaming and creating these Teflon catheters while at the conference. And immediately after the conference, Dr. Dotter flew Bill Cook out to the University of Oregon, where he was the chairman, and they set out plans to create the first Dotter dilatation set. Of note, Bill Cook remembers that Dotter made 10 catheters while at the meeting, and which Bill Cook subsequently sold later in that same meeting. So Charles Dotter was Bill Cook's first employee. So when was IR born? January 16th, 1964. So on January 16th, 1964, Dotter and his trainee, Melvin Jenkins, first used the catheter for intentional. Now, his prior one was unintentional. This was intentional percutaneous transluminal angioplasty. The first patient to benefit from this was named Laura Shaw. She was an 82-year-old female who was admitted to the University of Oregon with a painful left foot, as you can see up in the upper right there. The foot had a non-healing ulcer and gangrenous toes. The gangrenous toes were not sloughing. And her physicians recommended amputation, but she refused. So Dr. William Crabtree, a general surgeon who handled the vascular cases at the time and had a good relationship with Dr. Dotter because of his angiographic abilities, saw that Mrs. Shaw refused surgery. And so he asked Dotter to see if he could do anything to improve her situation. And then, so Dotter performed an angiogram and found that she had a short segment stenosis of her superficial femoral artery. And this was an ideal situation for Dotter. He had in his possession at that time, Bill Cook had delivered the previously designed dilating catheters here on the screen. Sorry, here on the screen. And the procedure went well. Within minutes, her foot was warm, hyperemic, and the ulcer soon healed, and the dead toes, properly sloughed off, and she subsequently died 3 years later, walking on her own 2 feet. So that was the first transcatheter intervention. So the first intervention with the catheter. This was the first dictation, which I'm not going to read this morning, but it is illuminating that he described the technique fairly well. Was honest with the procedure. But after the first successful procedure, Dotter started a very aggressive campaign to recruit patients and gain recognition for his newly developed PTA, percutaneous angioplasty. Surgeons, of course, were not really interested in non-surgical treatments for atheromatous disease, and were even somewhat opposed to PTA. So Dotter went out by himself and recruited patients with a family practice people. He used money from the department to gain some national level of advertisement, eventually being written up in Life magazine. This national publicity eventually attracted a very wealthy patient from New York. So Dotter and his team flew out to New York and performed remote PTA on this patient who did very well, and subsequently donated a large amount of money to his department at and his research lab at the University of Oregon. This money actually paid for a 1-year research fellowship for someone named Joseph Roche, which we'll get to know a little bit later. Eventually, Dotter published multiple papers on this. However, PTA procedures were essentially only being performed by his institution at the University of Oregon. The rest of the United States was not very interested. However, European angiographers were very interested in this. They found this to be an amazing technological leap. In particular, Werner Portzman from Berlin started experimenting with Dotter's procedure, and he even would put slits in the side of the catheter and put a balloon, blow up a balloon inside the catheter. This is a picture of now we're progressing along the PTA history, the percutaneous transarterial angioplasty. And after Daughter kind of described his technique, the birth of interventional radiology in Portland, Oregon, it went very quickly across the Atlantic into Europe, where, as I said, Werner Portsman progressed it. There's another doctor from the Netherlands, Van Andel, that modified his telescoping Teflon catheters. And another, Herbert Zettler from Germany, again, started calling it dottering of diseased arteries. So they used Daughter's name, I guess in German fashion, as a verb. And this inspired someone to develop, there were some complications with the dottering technique, though. Plaque would be dislodged, thrombosis would occur, and you needed a very large sheath to go from point A to point B. So there were other people out there trying to, again, in Europe, trying to improve this. And that's when Andreas Grutenzig, maybe Fabian can help me with the name, came up with the balloon angioplasty. So Daughter had in the past used a Fogarty balloon in an attempt to balloon open stenoses. He tried reinforcing the Fogarty balloon, but nothing would work, and frequently thrombosis would occur. However, Andreas was able to work with a retired chemist, I guess, who had deep knowledge of polyvinyl chloride. And together they were able to with a blowtorch and some steaming equipment, create a very stable balloon that had high forces, and that was able to, because they had used one of Daughter's techniques of creating 2 lumens, they were able to put it into the vessel at a very small size. And Andreas had a different approach than Daughter. Daughter was very emotional about his beliefs. Andreas presented himself as very scientific. So Andreas's fame and acceptance of Andreas knew that he was standing on Daughter as the originator of the idea, except Andreas just brought it to the next level. But Andreas gave a lot of credit to Daughter for doing this, and this elevated then Daughter's work in the United States. And eventually, the combination of these 2 people, percutaneous angioplasty was then brought back into the United States by these gentlemen. So and some of these gentlemen actually went to work with Andreas and fell in Europe to see what and how he was doing. And so we have just to name a few, there's Brian Katzen, who has the Katzen wire, the Cumpy, David Cumpy, the Cumpy catheter, Tom Sauce catheter, and there's Ernie Ring there, and Teggett Meyer there. So these all these gentlemen brought PTA back into the United States. So let's then switch topics quickly to another one of Daughter's passions, which was the Coil Spring. Essentially his first concept for an arterial stent. So percutaneous vascular stenting was first explored by Dotter in dogs in the late 1960s. Dotter suggested an expandable coil spring that was either stretched out or wound around a controlling mandrel that he developed, and could be placed in through a smaller lumen and then expanded once it was inside the patient. However, he never got a design that worked really well. As you can see from the image here, his introducer sheath was essentially the same size as the stenosis, and he would just leave it behind. So his version never really caught on. However, there were other versions. This was another version of his stent. Cesar Gianturco and Hans Wallsten developed stents in 1985 that were essentially self-expandable stents. So they were constrained within a catheter and then placed in the patient and expanded on their own. They were of different designs, but they both are still in use today. Then there was a third person in 1985, Julio Palmaz, who developed the first really successful balloon expandable stent. He essentially, under low power microscope, weaved these stainless steel wires together and polished them so that they would be bonded. And he crimped it himself then over a balloon, and then that would be inserted and expanded. The technology in this balloon has changed over time, but the basic concept is still the same. Interestingly enough, Julio Palmaz has now transitioned his career into winemaking, although he does still comment on stent technology. So we did Dotter's understanding of angioplasty. We looked at some stents, but now let's look at another form of treating lesions via the catheter, which was GI bleeding. This was mainly originally researched by Stanley Baum and Moray Nussbaum. The treatment of acute GI bleeding really developed in the 60s. These two gentlemen were able to show active extravasation at 0.5 mLs a second. And they found that if they infused vasoconstrictive medications into a distribution of vessels, like a low-dose vasopressin into the SMA, they could actually control not only arterial bleeding, but also originally they were using it for variceal bleeding. And this caught on, especially on holidays, nights, and weekends, similar to our life now. However, the procedure at that time was much more collaborative. Patients would come into a regular 1960s angiographic suite with the GI doctor, with the surgeon, and they would participate together in these patients that were essentially exsanguinating to start these vasopressin infusions. The nice thing about that at the time was that because everyone was in the same room, the angiographer was considered more of an acting clinician, so less of a technician and more of a clinician. And that's one of our first forays into clinical care. GI bleeding was further. It had a medical technological invention by Joseph Roche. Joseph Roche, who you might remember was a Dotter's first research fellow. In 1970, he performed the first selective arterial embolization with the injection of autologous clot for a patient with pyloric ulcer and advanced cirrhosis. He advanced the catheter deep into the GDA, injected autologous clot, and then started, which was the standard of care at the time, an epinephrine infusion. And 14 hours later, he brought the patient back and the artery was still occluded. So that was a major advancement at the time. However, variceal bleeding was still an issue. In 1974, Andreas Lunderquist, back in Europe again, developed a transhepatic portal approach with directly coiling or embolizing varices. They would sometimes mix glue or gel foam mixed with STS, and G-Interco coils were then placed into these. You can see here, he embolized the varus here. However, there was high complication. There was a moderately high complication rate with portal vein thrombosis, but more importantly is that the patients would then bleed again from other sources. And we'll revisit this in just a minute. But following along after GI bleeding, we're going to touch base on thrombolysis. So during doddering of arterial stenoses, daughter frequently ran into the complication of thrombosis. So Garner, in 1933, Garner first discovered that streptokinase was created as a bacterial protein. And then Pilling discovered that in human urine, there was also a thrombolytic enzyme which was subsequently named urokinase. And these were found to be very effective in breaking up clot when injected directly into fresh clot. And over the years, these have been, the techniques have been refined with Barry Katzen, the Katzen wire, Ben Brenda, Gary Becker, and the Thomas McNamara. All of these catheters are still widely used today. Thankfully, now we have recombinant TPA as the allergic reactions and other complications. Half-life is much less. Barry Katzen then went on. He was one of the major advocates for clinical care in IR, ownership of his patients. That's it. I want to touch base quickly on Sidney Wallace, as interventional oncology has become a huge part of the interventional radiology practice. Sidney Wallace actually had renal cell carcinoma. His renal cell carcinoma was preoperatively embolized at MD Anderson, his institution. And he actually at the time wrote that he believed that there was an immunologic response after the embolization that protected himself from dying of the disease. He eventually did succumb to the metastatic RCC to his pancreas, but it took 18 years after his embolization. So that was, and he wrote extensively about this experience. So let's go back to the bleeding varices. So in 1969, experimental tips in canines was being done. It started by inadvertent entry into the hepatic portal branches during something called transjugular cholangiography. So way before we did percutaneous cholangiography, the original cholangiography was done transjugular. So people would go, in through the neck, down into the hepatic veins, and define the biliary obstructions by poking into the liver. Occasionally, the portal vein would be accessed, and people then, this catalyzed people to explore the new technique of decompressing the portal system through the liver. Colapinto in the 1980s pushed this even further. What he did is he got portal access and left a balloon from the hepatic vein to the portal vein up for 12 hours. And this, after the 12-hour dilatation, he took it down, and patients did well with control of their bleeding. However, stenosis, eventually the connection closed down. So this group of interventionalists, particularly Jean LaBerge and Ernie Ring, and eventually Palmaz, came up with the idea of stenting the connection between the hepatic vein and the portal vein. The United States was still wary of doing these procedures. So the first one was done by Richter in Germany with the help of Julio Palmaz. And the first procedure was technically successful. However, the patient acutely decompensated because of respiratory distress. However, they persevered on, and the subsequent patients did well. And that was in the mid 1980s, or 1988, January 1988 was the first successful stenting of a TIPS. So not to divert too much, but here's another question. How did pulmonary angiography help drain the biliary system? So I'm going to read you a little story about Ernie Ring here. So Ernest Ring in 1967 was doing percutaneous biliary drainage using techniques learned across the pond by Lunderquist. And he would simply, transhepatically percutaneously puncture the bile ducts, and eventually he experimented with different guide wires and catheters to drain the biliary system. He found that the Grolman pulmonary catheter, with a few extra side holes placed, did a very good job of draining the biliary system. So Ernie Ring then called Ross Jennings, who was then the head of manufacturing at Cook, under Bill Cook, asked him to create some Grolman catheters with extra side holes. And that is now the Ring catheter, Ring biliary drainage catheter. And you can see here that the Grolman and the Ring essentially are identical, except the Ring biliary drainage catheter has extra side holes all the way back 10 centimeters across the bend, whereas the Grolman doesn't. I'm not suggesting using a Ring catheter in the pulmonary circulation today, but back then there was essentially the same catheter. So who was the first IR fellow? Melvin Jenkins. Melvin Jenkins was sent by Dotter to study under Mason Sones, and Melvin Jenkins to learn coronary angiography, and then, which he did very well. Jenkins perfected the transfemoral technique for selective coronary cholangiography. And he and Mason together formed the Society of Interventional Cardiology in 1967. So the first fellow under Daughter went and formed interventional cardiology. Joseph Roche, this brief synopsis of his life doesn't really do him justice, but he consistently, people who trained under him, he had a few good teaching points. One of them, which is relevant to us today, he would say that if you were unsuccessful after 5 minutes trying to select a certain artery, you should either change your catheter or change the hands doing the procedure. And so he has also written a biography. Before he passed, he wrote a biography which on his life, which is very interesting. So who coined the term interventional radiology? Margolis in 1967. He emphasized, he defined IR as a manipulative procedures under fluoroscopic guidance that may predominantly provide therapeutic or diagnostic in nature. He did emphasize the need for special training, special technical skills, clinical knowledge, ability to care, close cooperation with other services, and imaging expertise. And this was back in 1967. The name debate will always continue. Daughter himself was not enthusiastic originally about the term interventional, calling it imperfect. His main reservation about intervention was that it lacked specific definition of the work that we did. And he believed that the term would lead to confusion among the lay people and many physicians. He was probably correct at the time. Daughter himself defined interventional radiology as a variety of percutaneous image guiding alternatives or aids to surgery. Eventually, Daughter accepted interventional radiology as the name, as it allowed growth of interventional radiology and how it didn't define us. So it allowed us to grow. What is skiver, and SIR? This is just to say that in the history of SIR started with Stanley Baum, the interventional radiologists that we discussed the GI bleeding with. And in 1973, he conceived the idea of having a society devoted to the radiologic study of cardiovascular disease and intervention. And he helped organize a meeting at Massachusetts General Hospital. At the time, he brought together the various angio clubs across the nation, as there was no national society in 1973. In 1974, late in 1973 and then on to 1974, there was another meeting. And in 1974, the Society of Cardiovascular Radiology was formed. The first meeting occurred in the Ocean Reef Club in Key Largo, Florida in 1975 with 24 members. And oops. Yeah. These were the founding members. And then the increasing scope of the specialty, the growing importance of our therapeutic activities resulted in its name change to CVIR in 1983. Unfortunately, in 1985, Daughter died, but in 1987, the members of the SCIVR met and decided to expand membership to not be as exclusive. The then leaders recognized that an open scientific exchange was vital to the survival of IR. And they needed more volunteerism in the society. So in 1987, the society was open to everyone. And then in 2002, the name was formally changed to Society of Interventional Radiology. One comment on Dotter's clinical care. This is a quote that everyone needs to know. It's almost on every Dotter lecture. And so during a talk at the American College of Surgery, so this isn't radiology now, he's giving a talk in the American College of Surgery in 1968. Dotter said that if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, they will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skills others can learn. So he's essentially saying, clinically, we need to take responsibility. In a 1980 editorial, his thoughts on the matter had crystallized further over time, and he stated that the angiographer who enters into the treatment of arterial obstructive disease can now play a key role if he is prepared and willing to serve as a true clinician and not just a skilled catheter mechanic. Eventually, Dotter said it another way. He said that if we do the job well, we keep it. If not, we will lose the techniques we developed. And so that's a very important progression in his thinking. Essentially, the need to own the patient clinically, round on them, see them before and after the procedure is absolutely critical to continue to being able to practice interventional radiology. So we've gone through the Dotter vision and all that he's developed. We visited, oops, I don't know why that's doing it. We visited the 1960s, 70s, 80s, oops. Sorry, my computer's freaking out. So we're going to focus now on some of the Dotter's tenets. So these are what he tried to project onto his trainees. He would tell them to examine the patient and concern yourself with improving the diagnosis and potential ways of percutaneously treating whatever he found. For emergencies, he wanted his trainees to always be prepared to innovate. And as I said in the last slide, if we do the job well, we'll keep it. If not, we'll lose the techniques we've developed. So the future of interventional radiology can be seen here in this Venn diagram. Our unique skill is the combination of our imaging skills, clinical skills, and technical skills. But there's advances in here. So there are areas in between these where interventional radiology can continue to contribute and grow. Because innovation is something that is on top of all of these skills that we do as who we are as a people. So between imaging skills and clinical skills, we could use AI. Between imaging skills and technical skills, we could advance robotics. And between clinical skills and technical skills, personal EMR automation. These are all areas ripe for interventional radiology progressing our field forward. Here at Yale, we have a clinical team, a consult team, a procedure team, and a rounding team, and patient care coordinators. So going back to, hopefully this movie works this time a little bit more. Here we can see that on my first call at Yale, I used the Selingers technique to get access. I got into the hepatic vein. I got into the vein of Laberge. Well, first I got into the right heart and did heart pressures. And then I got into the vein of Laberge, and then I got access with a Compi catheter into the right hepatic, and I got percutaneous access into the spleen using, again, Selingers technique and some of the stuff that Lunderquist developed. I did a portal splenomegagram, saw that the portal vein was completely thrombosed, saw the large esophageal varices, saw that the portal vein was thrombosed. We saw that we could not cross into the portal vein easily, so I put up a snare. Again, Daughter developed foreign retrieval techniques, mainly because his Teflon catheters might break and he had to snare them out. So then we did an angiography there. We snared the wire, pulled the wire through, did angioplasty using Andreas's balloons, dropped a stent using a modified something between a Palmaz and an Indian Turco stent. And then we coiled off using essentially Gian Turco coils. And then someone who I didn't mention is that we capped it off with an Amplatzer plug. All right, I skipped today. So then we have, just briefly to go through, so now interventional radiology, we're doing pulmonary pharmacomechanical treatments. We are embolizing bronchial arteries. We are stenting SVC syndrome. We are placing, portosystemic shunts in patients to decrease bleeding. We are getting out into the fourth order branches in the GI tract and embolizing them. We are draining obstructed visceral organs, so pus under pressure in the GI tract and in the GU tract. We are treating cancer through the arterial system. We are treating cancer percutaneously. We are still stenting vascular structures, and we are embolizing benign disease to increase patients' quality of life. And we are still declotting thrombosed veins. So I hope this gives everyone a good broad introduction to interventional radiology and some of its history.
Oh, thank you so much, Todd.
Yep.
This is a very good history, very good sequential talk of where interventional radiology is coming from. It's very inspiring. I've had many talks about, maybe one or two talks about the history of IR, but this sequence is amazing. Like the way this talk is put, the cases is phenomenal. I think I like it so much. It's something I think I always have to look for. The quotes that were there were so inspiring. Thank you so much.
You're very welcome.
Yeah, thank you for.
All right. Well, thank you for inviting me. It was a pleasure.
Thank you. It was good having you.
If you have any questions, feel free to email me or.
Yeah, sure. Thank you so much. Thank you for your time.
Thank you.
Do you mind showing us the first slide? I want to take a picture of the first slide so that we can use it. The first, yeah. Oh yeah, I have it. Want to take this? Thank you so much.
All right. You're very welcome.
Have a nice day.
Take care. You too. Be well.